If you do well in the CBS, then you do well in the exam. If you are not doing well in the CBS, then you are in trouble. My name is Sanant. I work as a intensivist at the Townsville University Hospital in North Queensland in Australia, and I'm also affiliated to a university, James Cook University, as a senior lecturer. Just going briefly about the course that we look at, and then we'll go to the CBS. So the course is going to start next week, early next week. And we have divided the course into 10 modules, as the post was saying. Each module is of a duration of 7 days, 1 week, which we provide some pre-reading material, which we call it as a TRICS cloud, which you have access each week to a specific chapter, and then appear the online exam on Saturday or before Saturday, and we do the debrief on Zoom with the question maker who has made the question, usually EDIC qualified person, and we do the debrief along with some faculties, mentors there. That happens for 10 weeks to cover the whole of the syllabus, and 11th, 12th, and 13th week are the important part of this course, because that's where the one-to-one interaction with the examiner happens. So each candidate will get at least one exam, like 3 exams in 3 consecutive week, one-to-one with the examiner, clearing their doubt, getting their marks face-to-face on the Zoom. So that's the whole structure of the exam, which runs for around 14-15 weeks, depending on how many candidates are enrolled and when we can fit them into the one-to-one interaction in the final module, which covers the whole of the 10 modules. So that's basically the whole course structure. It looks at the at CCS and CBS, which try to simulate the EDIC exam. As Tapas was saying and Adrian was saying, the examination is getting more and more practical based, so we are going to modify our pattern also, making it more up-to-date. It is up-to-date, but making it more relevant, which will have more success rate in the exam. This is the module that Tapas was talking about. So we are in the second introductory class. We haven't started our first module yet, which will start next week. We'll share the study material 1 week before the start. And these are in addition to the ACE module that you get along with the ESICM. So they are not a substitute of the ACE module, rather they are something that you have more information about a chapter, you go and study. They are very targeted chapters. So these are in addition to what you get during the ESICM registration. Then these 10 weeks after that, you have 3 whole syllabus mock tests. So each module has 1 mock test. So 10 plus 3. 13 mock tests in total. What we discuss in that mock test or chapter-wise mock test is typical question that is asked in the exam. So I'll go ahead with few of the CBS that can be asked, usually gets asked. It's not about the particular question that comes in the exam, it is the pattern of answer that is important. So if you are shown a CT brain, how do you approach that CT brain? That's the most important thing to learn, because that you can apply into 10 or 12 CT brain possibilities, right? So that's what the main aim of this course, to give you a structure answering format to questions, so that when it comes, it is not alien to you. For example, this lady who was crossing a busy road was hit by a car. Her main injury was severe traumatic brain injury, and her CT scan is as shown here. So the question, the CBS question was, describe 3 important CT scan findings and outline 2 important management strategies. So very specific question, and we should be having very specific answers. I will ask the candidates, whoever can participate in this in a what you call two-way discussion, rather than me just talking around and showing you the pictures. So if somebody can volunteer to answer this, then I can run it quickly.
This is right temporal contusion with surrounding edema and some midline shift.
All right. Anything else?
And to import these 3 CT findings, and there is some subarachnoid hemorrhage, not sure. Yeah. 2 important management strategy, like we have to reduce intracranial pressure monitoring and the anti-osmotic measures like mannitol and hypertonic saline.
All right, that sounds pretty good for the marks to fetch. So the important thing when you look at a CT brain, there are not many things that is there, right? Either there is a skull fracture, either there is a contusion, either there is a hemorrhage, either there is a midline shift, either there is hydrocephalus, or either there is herniation. There are 6 or 7 things, or any foreign material in there, like a EVD or a Codman catheter. So there are 6 or 7 things that are important in a CT scan to look at. So if you look at this CT scan, which side? Yes, you are correct. What sort of hemorrhage? What sort of contusion? Edema present? Yes or no? The brain looks more crowded, and there is loss of sulci and gyri, suggestive of signs of increased cerebral edema. So very specific 5 or 6 things you look for CT brain. Don't have to beat around the bush. So it has to be very particular. You are correct in identifying most of the abnormality here. The answer pattern that we have suggested is right frontoparietal contusion with hemorrhagic transformation of the contusion. With bilateral frontal horns of the ventricles are compressed, there is no skull fracture, no midline shift or mild midline shift in that case. Now, how do you manage? Two important management strategies. So broad category that you need to tell. So limiting secondary brain injury, which includes aiming at a particular sodium level, normoglycemia, normocapnia, adequate sedation and analgesia, and head-up positioning. Anti-edema measures, hypotonic saline as required, and escalation of sedation, analgesia, or paralysis, and management of complications. So this is important. When they talk about how do you manage, you always look for the complication that can happen, right? So in a traumatic brain injury, the most important complication is a raised ICP situation, which is managed either medically, followed by surgical. Medical is barbiturates, and surgical is decompression or decompressive cranectomy. So basically, you classify your answer, take half a minute to answer that, right? So if you know how to prepare your answer for the exam by practice, then only you can tell the right point in the exam. Otherwise, it will be very, and they will look for everything, like whether you have talked about tier 1 treatment or not, whether you have talked about complication or not, whether you have talked about pharmacological treatment or not. So you have to have at least any two of the three. 1 category, 2 category, 3 category, any 2 of the 3 needs to be there, otherwise you lose half mark, right? Similarly, this patient was transferred to ICU with severe traumatic brain injury, and ICP monitoring is placed, and that's what you see as a waveform. Which one of the following is a normal waveform, A and B, and what are the various methods of ICP monitoring that you know? Can anybody volunteer for that?
A is a normal ICP waveform. B is pathological because P2 is more than P1. And there are various methods like intraventricular, what is that, probe, and intraparenchymal, epidural, subdural.
Right, correct. That's it. That's it. You need to tell the name, what it is called. Intraventricular is a external ventricular drain, EVD. Intraparenchymal is a Codman catheter, subdural bolt, and etc. Right. The answer is correct. So A was normal, intraventricular, subdural, epidural, or parenchymal Codman catheter. Straightforward answers, right? Now the 42-year male post a car accident, sustained a grade 3 liver injury, required multiple crystalloid and massive transfusion protocol, shifted to ICU from emergency, and noted to have the following ECG, which is there in the right side. The core body temperature was 31 degrees centigrade. So what is your diagnosis and what is the management?
The ECG diagnosis is like the patient is having hypothermia Osborne waves. And probably you have to, management is gradual rewarming of the patient.
All right. So this is a bit, as Adrian was saying, you need to read the history properly so that you can answer. You are correct. There is Osborne wave, and that's first part of the answer is correct. What is the management? So he has already received massive transfusion protocol, right?
Yeah.
Why he has received massive transfusion protocol? Because either he is coagulopathic or he is bleeding actively, like surgical bleeding, right? So hypothermia, how does it affect coagulation? That is the important thing, right? So you have to correct or do active rewarming to a safe level like 35 degrees centigrade and correct acidosis and prevent any other causes of coagulopathy, because he has already received massive transfusion. You don't want him to bleed again. So that's how you read the question and frame your answer, what he is asking for. If you start saying, oh, I will take care of A, B, C, secure the airway, 100% oxygen, all those are correct, but that's not the question is asking for, right? So need to have a different approach to the question. What the patient has, grade 3 liver injury, who is hypothermic with a Osborne wave, who has already received this much of massive transfusion because of the bleeding. The most important thing is to correct the coagulopathy, and correct, which can be done by normothermia, maintenance of acid-base homeostasis, and other factors which are going to be going to cause the patient bleeding or more prone for bleeding, such as calcium level and other factors, right? So Osborne wave with hypothermia, management, active rewarming to 35 degrees, avoid acidosis and coagulopathy. That's the most important two things. If you don't answer that question, probably you'll get half of that mark, not this one. Rewarming, yes, but why are you rewarming the patient? That's what the examiner will be looking to know, whether it is just to make the number correct or whether you are anticipating any complication with hypothermia or ongoing hypothermia. All right.
Okay.
Right. This is CBS 3. This elderly lady who is on warfarin with a complex cardiac history was gardening when she fell over and struck her head. She presented to ED confused with obvious left-sided hemiplegia and left-sided facial droop. Her CT scan as shown here. What is your diagnosis and what is the management?
Right-sided intraparenchymal hemorrhage in the posterior part of the posterior parietal, right posterior intraparenchymal hemorrhage, and the management will be same neurosurgical. We need to involve the neurosurgeon early, and in the meantime we can the airway breathing and along with the avoiding secondary brain injury because of maintaining electrolytes, hypoxia, normocapnia, seizures and hypoglycemia to avoid, start the anti-osmotic like hyperosmotic measures, and transfer to the the OR once they are ready to do the burr hole and evacuation of hematoma.
All right. Anyone else has any other thought about it? The management part?
You want to reverse your optimization.
Yes, so that's the most important thing. Somebody bleeding with a in a essential area of the brain with motor abnormality. You don't need that bleeding to progress, though it doesn't have or hasn't given an
Tranexamic
INR.
acid.
Right, okay. Hasn't given you an INR there, but the reversibility with the warfarin is what you do, the first thing, right? Of course.
Tranexamic acid.
Correct. These are all supplementary therapy, but the most important thing is to reverse the coagulopathy. That you have to interpret from the history. Somebody with warfarin has demonstrable motor weakness or motor presentation there. The first thing that you do is to correct the coagulopathy again. How do you do it? Depending on your center where you work. Now, the other thing is, if it is suppose not a warfarin related bleed, if it is something else like a hypertensive bleed, then they will ask you about, sorry, this is BP, not BO. They will ask about a target blood pressure. Okay, that is very, very important. So in this case, if you look at the answer, so right temporoparietal bleed with midline shift with cerebral perilesional edema. Always look for talking the CT scan in 3 or 4 points. Which side? What sort of hemorrhage or what sort of abnormality? Is there any edema? Is there any midline shift? This is the important thing to look for, the 4 and 5 points. For this patient, as someone said, attending airway breathing needs, so the first priority, target the blood pressure less than 140 because it is a hemorrhagic stroke with a reason of warfarin, and reverse the anticoagulation depending on where you are. It's a European center, so it is prothrombin or prothrombin concentrate. You can think of FFP and vitamin K. And of course, surgical consult, depending on what they say, clot evacuation, yes or no, and then the neuroprotective measures to avoid or prevent secondary brain injury. If you tell these 5 points, there is nowhere else they cannot give you 1 mark for that or whatever mark assigned for that. That's why any 4 of the 5 you need there to be ticked off, right? It may not be 1 mark each or 0.25 mark each, but every point will have a mark. So whether it is 4 marks, then we'll give 4 out of 4 or 2 out of 4, depending on how many questions or how many points you are talking about, right? So always when there is a management question, make sure that you're correcting the cause of it, right? That was a bleeding due to warfarin. You need to reverse the anticoagulation. Now, this is a question, scenario 4, 45-year obese patient with grade 2 liver injury, post a road traffic accident, being managed conservatively in your ICU. Vitals were tachycardic at 114, blood pressure 90/60, tachypneic at 28, and saturation of 92% on room air. Hemoglobin is 10. White blood cell count is 12.2. Platelets are 1.5 and INR is 1.4. APDT 26, and initial chest X-ray was apparently normal, and the echo showed moderate RV dysfunction, right? And this is the CT scan. What is your diagnosis? What is the intervention required and the role of thrombolytic in this patient? So they will face this question one after the other, because if I say thrombolytic, you will say, oh, there is a thrombus there, I need to talk about it. So it's a pulmonary embolism. But this question will not appear in the first go. They will ask you, what is your diagnosis?
Bilateral pulmonary artery thromboembolism.
Yep. So saddle embolus in the main pulmonary artery extending bilaterally, right? Now somebody asked about pulmonary embolism and subarachnoid hemorrhage. How do you treat? It's a similar question. Somebody who has a bleed, how do you treat? So what will be your answer?
Surgical embolectomy, mechanical thrombectomy, or aspiration of the thrombus.
Mechanical thrombus.
Yep. All right, let's see what it is. So first one is correct. Systemic thrombolytics are contraindicated because only 2 or 3 days old, grade 2 liver lac. Pulmonary thrombectomy, catheter directed or aspiration. Heparin infusion, the patient needs a maintenance of treatment, heparin infusion, if the surgeons are happy. So that's the other part people will miss always. So they will talk about thrombolysis or extraction of the thrombus, but they usually miss this part, heparin infusion, that the patient needs to be on after the thrombolysis, right? If the surgeons are happy with it. They can go from here to IVC filter if the patient has recurrent thrombus, or the indication of IVC filter, and all those things can be asked in addition to this, okay? So that's what we are going to talk about in our CBS. When the relevant chapter is there, we'll talk about the peripheral questions that can be asked in each of the CBS also. Now, case scenario 5, 36-year-old, fall from two-wheeler, conscious awake, 15 GCS, heart rate 110, blood pressure 88/50, 18 respiratory rate, right-sided abdominal pain, and first scan was done, as you can see here. Interpret the image, and what is your next step? Take this as the liver.
Fast.
Pneumohemoperiton. Pneumohemoperiton.
The patient has a fluid in the what do you call it? Hepatorenal pouch, so possibly is a hemoperitoneume.
Air collection.
Okay, and then what is the next step?
So next step we should go for a
The same resuscitation, we have to continue with the resuscitation and close monitoring and we will continue the CBC every 6th hourly. If she remains stable, like blood pressure is not dropping further with resuscitation.
You can go for a contrast CT.
No,
EFAS is
Con-
positive.
it's a hollow viscous perforation. I think it's a free
Hemodynamic
air
instability.
between.
Exploratory laparotomy has to be done because the patient is
Patient
already
should be planned for
hemodynamically unstable.
exploratory lab.
Because after initial resuscitation, surgery consult and shift for exploratory laparotomy since EFAS is positive and patient is hemodynamically unstable.
All right. Okay,
Now-
that's sensible. But is there an option of is there an option? All right. Can we mute the
Correct.
microphone?
Karava.
Oh, sorry. All right. I would request everyone to mute their microphone, please. All right. Sounds good now. Okay. So all of you guys are correct, but partly. So it has to be all in one answer, right? So free fluid in the Morrison spouse, that is correct, because you saw the liver, you saw the kidney, and there is fluid where it should not be. So free fluid, kidney, liver. There's no air. So air is totally like it will not allow any ultrasound beam to pass. So this is all fluid or blood. Now, somebody told about airway breathing. Yes, attend to the airway breathing priorities. First point. If the patient is hemodynamically stable, or after resuscitation the patient is hemodynamically stable, then he can or she can have a CT abdomen with contrast or angio to see for the bleeding and angioembolization plus or minus, right? If the hemodynamic is unstable, that means there is ongoing bleeding, you're not able to take them to a CT scan, then probably go for laparotomy. So these are the two approaches that we do. That's the usual surgical approach in any hospital, I believe, right? And the fourth point is, if the patient has any reason, medical reason to be bleeding, then correct the coagulopathy and tranexamic acid. So these are the basic 4 or 5 points that you need to tell, right? You cannot waste your time talking about looking for a saturation of 94%, making sure giving oxygen. Yes, the one-liner, airway and breathing priorities needs to be attended. If hemodynamically stable, or if responding to the resuscitation, then for a contrast CT or a CT angio, look for a bleeding source and possible angioembolization. But if hemodynamically unstable, suspected of ongoing bleeding, then needs to go to the theater directly, right? Other optimization would include correct the coagulopathy and tranexamic acid, right? So everyone knows about how to manage, but the main thing is to vomit that in that point of time. So how do you vomit that? To practice it. How do you say, or what are the points you say first rather than the last? So these are the things needs to be bit polished with more and more practice. Right. This one is a 35-year-old alcoholic male was admitted to the ER with an altered level of consciousness, which improved rapidly with administration of glucose. After stabilization, he was shifted to the general ward, but 12 hours after admission, he developed altered level of consciousness again. Immediate CT brain was normal, and on examination, he had ataxia. Lab investigation as following, right? What is the cause of ultrasensorium in this case, and what is the specific treatment that needs to be given?
If Wernicke's encephalopathy, we need to give IV thiamine.
All right, great, 100%. So main thing is he's getting better with the glucose. Somebody is getting better with the glucose, and then it becomes again encephalopathy with a normal CT and ataxia. 9 out of 10, it will be Wernicke's encephalopathy unless there is a stroke or something, right? So very specific. Venous encephalopathy. Treatment is thiamine replacement, dextrose, nutritional supplement to monitor for refeeding, and magnesium replacement. Usually they are hypomagnesiemic, but not an important point. But you need to show your concern, and this viva can go to refeeding after this, right? So they will talk about refeeding syndrome after this for sure. So that was easy go. Ventilator waveforms, as Dr. Wong was explaining or saying. This can come as various ways. They can put a photograph of the whole monitor of the ventilator, or they can put a small video depending on what is to be done on that year of the exam. So it can be a dynamic picture also. Okay. So this patient is being ventilated with an FiO2 of 0.9. As you can see the picture here. What type of pulmonary deficit is suggested by the ventilator waveform displayed below, and list 4 causes of this pattern of pulmonary deficit. So this is a vague term, pulmonary deficit, or what sort of abnormality you can see, and what are the causes, possible 4 causes that can cause similar abnormality on the ventilator waveform. There is a ETCO2 reading here. Depending on which ventilator you are using, you may or may not have it, right? Any comments?
Hypoventilation and
Oops, sorry. Sorry.
Hypoventilation, rebreathing, maybe hyperthermia causing increased CO2 production, maybe increased feeding, like more glucose, carbohydrate.
Okay, let's go step by step. First, the abnormality. What is the abnormality in the waveform?
So high end-tidal CO2.
Yes, correct. What else?
And low tidal volume. So 300
Yep.
ml.
Yes.
Prolonged expected phase.
Sorry.
Poor compliance of the lung.
Correct. How do you know there is a poor compliance?
High airway pressure and low volume.
All right. So this is a pressure control mode with a high airway pressure, low volume delivered, high EtCO2. That means the compliance is poor and we are struggling with CO2 clearance. Okay. Now tell me, what are the causes that can cause it? Stiff lung, that's what it is.
ARDS.
Yes, ARDS. Now, what are the causes of ARDS? What are the causes of ARDS? Everybody can tell that.
Pneumonia, pancreatitis, burn, inhalational injury, massive
sepsis.
blood in sepsis, massive blood transfusion.
Yep, you can tell n number of causes of that, but the way you do it is pulmonary, extrapulmonary. Okay, pulmonary infection, non-infection, extrapulmonary others, right? So pulmonary infection is pneumonia, as you said, trauma, contusion to the lung, TRALI, extrapulmonary pancreatitis, systemic sepsis, and all those things. So you just classify your answer so that the examiner gets that, or he knows about it, right? Rather than talking about pancreatitis first and then talking about pneumonia second, then talking about something else in the third. Because they have a grid of answer, right? And what is the probability that your answer is going to be in that grid? Otherwise, if you have to say 10 causes to get those 4 causes in there. So the best way to tell it is to classify your answer in the beginning, saying pulmonary, extrapulmonary, oh, he knows about it, the examiner will tell now. So that's how the trick of exam or trick of answers, right? And even if sometimes they say they don't prompt it, but if you say pulmonary, extrapulmonary, and infection, non-infection, you don't have to tell about pneumonia or fungal or viral pneumonia. So they do anticipate that whether you know or not, depending on how you answer that question also. So it is always good to have a pattern for all the syndromic presentations, such as ARDS or somebody with AKI or somebody with causes of decay or causes of pancreatitis, or those type of syndromic presentation needs to be have a pattern of answering, or causes of low consciousness state. So make a pattern of answer before going into the exam. So that's what we stress on in this course. to talk or to answer your questions in a pattern so that you don't miss the differential diagnosis easily. All right. So going to this, poor compliance of the lung, hypercapnia, impaired gas exchange, which is hard to say on this, but FiO2 of 0.7, that means that. Causes of ARDS, as you said, these are the things that is there, but always good to classify them in the beginning, and then that will give you more mark rather than sporadically answering those questions. 25-year-old gentleman has been mechanically ventilated for 5 days in ICU following admission for polytrauma that included a traumatic brain injury, multiple stab wound to the chest, and a left ulnar shaft fracture. There is a massive air leak from the chest drain. The ventilator display shows the following waveform, FiO2 0.7 again. What is the abnormality here? And outline the principles of management of this condition and list 4 therapeutic options. Pretty lengthy
Leak.
question. So abnormality to start with,
Is the leak.
but you have to tell where is the leak and how do you say it is a leak. There is a leak, it says in the stem itself.
Okay.
So why there is a leak, you think?
So volume is not reaching to the
Tidal
baseline.
volume is not reaching the baseline,
Baseline.
which indicates there is an expiratory leak.
Yes,
And
that's, yeah, okay.
And flow is being cut off before the next generation.
All right. So leak, first of all, because there is an abrupt fall in the volume, right? And not reaching the baseline is probably not the right answer because it always reaches the baseline, but always the volume becomes 0 at the expiration. So if there is an abrupt cutoff of the expiration like that, that means there is a leak, right? Now management, outline the principle or management of this condition. Basically, how do you manage a pneumothorax with a bronchopleural fistula on a ventilator? That's the question. So management principles and therapeutic options. Okay. Anyone can try?
Like we can reduce the rise time. We can.
Correct.
Reduce the PEEP,
That
reduce
will
the
reduce
volume.
the leak.
Go ahead.
And another
For
is
pressure,
the HFOV, high
for
frequency
bronchopleural
oscillatory.
fistula, we prefer a pressure control mode.
Pressure control ventilation.
Okay. Right. So organize your answer. Somebody can organize the answer and tell. So first, whenever there is a ventilator question, talk about what mode, right? Pressure control ventilation is preferable, yes. Then talk about any parameter, flow, volume, rate, whatever you want to. So you want a reduce the inspiratory rise time, so increase the flow, yes. Respiratory rate, increase or decrease?
Reduce the rate.
Reduce the rate, right? Okay. Anything else that you want to do? Make the patient breathe spontaneously and extubate as soon as possible to prevent positive pressure induced further worsening of the pneumothorax, right? So that's the management principle. So volume time curve, the waveform has a sharp decline, suggestive of leak, suggestive of bronchopleural fistula. First they asked about the principle. So minimize the flow, reduce the transpleural pressure gradient, right? And spontaneous breathing and extubate as soon as possible. These are the main goal to manage a bronchopleural fistula. How do you do? Possibly low tidal volumes, set a slow rate, short inspiratory time, minimum PEEP to maintain the adequate oxygenation. As you said, other modalities of ventilation, double lumen tube, bronchial blocker, HFOV you can think of. Surgical repair, early surgical repair, if you ask them to be seen by a thoracic surgeon and give a opinion, but usually they are self-sealing mostly. And positioning, put the good lung up, that may reduce the fistula leak. But main option when you are talking about a ventilation, you talk about the mode, and then talk about either any parameter, volume, rate, flow, but in a systematic way, and just not reduce the PEEP. That's not the answer. So it has to be a complete answer, right? I will argue that we don't have time for this. How do we answer? But practice will give you more points because the answer sheet or the grade is always broken down into many parts. It's not about only one answer. Right. You guys are interested, then I'll continue. Otherwise, we'll wrap up.
Please continue.
All right.
Please continue, sir.
2 out of 30. That's not a good number, though.
Continue, please.
All right, sure.
Sir, continuous.
72. Okay. 72-year-old female admitted following crush injury of the right leg and was admitted to ICU. Post resuscitation and noticed to have the dark color urine next day with oliguria. Diagnosis and how will you treat? Straightforward question.
Rhabdomyolysis.
Rhabdomyolysis.
Yeah.
Rhabdomyolysis. IV fluid. Resus.
Generous hydration, fluid target urine output is around 2 to 3 ml per kg per hour. And there is some we can do in this case bicarbonate,
Urinary alkalinization.
urine alkalinization, and still if there is no urine output and all, then we can think of the renal replacement therapy.
All right, so that's a complete answer actually. Well done. So the point I have put in this question is not to muck around with the answer here. So if you see this with that clinical scenario, don't give a big answer saying that, oh, the dark color urine can be due to dehydration, can be due to methylene blue, can be due to XYZ. These are not the answer. Spot on answer here, right? It is not talking about ARDS and what are the differentials of ARDS. This is a spot on answer. You have to tell this is rhabdomyolysis fitting to this clinical scenario. That's why I put in this question. So you have to judge where you have to tell straight away where the answer will be only 1 point, or where the answer, if they say, what is your differential diagnosis? So in that case, you have to classify your answer and talk about it, right? But in this case, there is no differential. This is rhabdomyolysis, okay? Now, how do you treat? Correct. Hydration, alkalinization, somebody said diuretics, but usually not, but you can. And dialysis, the indication will be hyperkalemia, life-threatening, uremia, acid-base abnormality. Then the question may drag into more of a renal replacement therapy in rhabdomyolysis, whether it is preventive. Can you do early dialysis in this patient? Whether it is preventive, has it shown any mortality benefit? All those questions can come, right? That can be dragged into the electrolyte management, all those things. So it's an easy question to answer. All right. Scenario 10. 30-year-old male alleged history of road traffic accident. Patient was driving the car and was hit by the steering wheel. The CT in the ED showed the following. What is your diagnosis? Outline the treatment. Enumerate 2 complications.
Aortic dissection.
Dissection.
This is aortic dissection. Treatment is we need to maintain the blood pressure in the low normal, like systolic of 90 and heart rate of around 60.
Wait, first give beta blockers, then alpha blocker for management.
And enumerate 2 complications like cardiac tamponade, and depends on the extension of the dissection. And then renal failure, ischemia of the leg, depending on the mesenteric ischemia, depending on the extent of this.
All right. Yes, everyone has given a correct answer. Now let's see what it is, right? Aortic dissection, no doubt about it, right? Outline the treatment, blood pressure and heart rate control with a target of systolic blood pressure of around 90 or 100 till it is secured or repaired. And then it can be controlled by beta blocker, followed by alpha blocker, as somebody said that, followed by definitive treatment, which includes endovascular or surgical approach. Okay, so you have to tell that. So the treatment doesn't stop only in medical. Oh, sorry. You have to talk about, you have to talk about the surgical part also, because you'll say, oh, we are in ICU, just we do these 2 things and this is done by surgeon, but it will not work. So this will have 0.5 mark or half of the mark, right? You have to tell that. Okay, now complications, ischemia as a complete group, which can be due to, which can lead to MI, bowel ischemia, limb ischemia, renal ischemia, spinal ischemia, causing all the complication, right? Stroke, MI, as I said, AKI and death. Any of those answers can be given, but Mainly, the complications are due to ischemia or bleeding, right? In this case, so you have to talk about ischemia and bleeding. All right. My videos are working probably. Yes. Oh. All right. So 66-year-old male smoker while driving a car, head-on collision with a truck and sustained a blunt chest injury, admitted to ED with shock. What is the differential diagnosis of the echo finding and what is the treatment?
So tamponade, cardiac tamponade, because diastolic collapse after. Treatment is same in the line of airway, breathing, circulation, disability and exposure approach, and definitive management will be the under echo, the drainage of the
Immediate
fluid and
pericardiocentesis.
pericardiocentesis. Yes.
All right, that's pretty easy.
Pericardiocentesis and the catheter.
Okay, they have asked about a differential diagnosis. So, pericardial effusion with tamponade, signs of tamponade is the answer. They can ask you why it is happening, why pericardial effusion happens or tamponade happens after a trauma. So you can tell about ventricular rupture, atrial rupture, aortic dissection, or just traumatic pericardial effusion causing tamponade in a subacute manner. So what are the mechanism of pericardial effusion they can ask about? How do you treat pericardial centesis or tapping? And if it is not possible, then thoracotomy and repair, right? So always a percutaneous intervention and a surgical. You have to talk both sides of things. When it is not possible, you go for the surgical. All right. 30-year-old male with significant history of smoking sustained a blunt chest injury while driving his bike was hit by a car. He was admitted to ED with right-sided intercostal pain, shortness of breath. Bedside ultrasound of the chest showed the following. What is the classical lung ultrasound finding known as, and what is your diagnosis here, and what is the treatment?
Lung point.
Right-sided pneumothorax, and the ultrasound is showing the no movement. Lung point, yeah.
All right.
And
good.
treatment is
Excellent.
intercostal chest drain sensation.
Yep. All right. Lung point, pneumothorax, intercostal chest drain. Easy question. Identify this modality of imaging. What is the significance of this test in relation to a raised ICP?
So it's transcranial Doppler.
This
It's
is the
optic
optic
nerve
sheet
sheet,
diameter.
optic nerve sheet diameter.
All right, that's the first part. Second part, significance of this test. How do you interpret?
It is more than 5 or 6 millimeter. That suggests raised intracranial pressure, and
correct.
Then accordingly we have to treat it.
Yeah. So optic nerve sheet diameter ultrasound. So we measure inner edge to inner edge. If the measurement is more than 5 millimeter bilaterally, not unilaterally, bilaterally, then it corresponds to a elevated ICP, which is more than 20, right? It's a non-invasive method of measuring ICP. So when the question comes, how do you measure ICP in a patient? So invasive, non-invasive. Invasive is transcranial Doppler and optic nerve sheet diameter. And non-invasive are those two, and invasive are like you talked about intraventricular, interparenchymal, subdural, epidural method. So this is the method of non-invasive monitoring of ICP. They can ask you what's the utility or benefit and what's the drawback of it. Like it's not a continuous measurement, very operator dependent, but it is non-invasive and all those things they can ask you about. What are the non-invasive? I told you about already. Yeah, as Tapas has talked about the tier 1, tier 2 therapy, so I'll not go into detail of that. Now this one, identify the injury. How will you intubate the patient with such an injury and complication resulting from such injury?
The widening of the intercervical, this one with the hematoma, retropharyngeal hematoma.
C6 fracture.
Correct.
What is?
C6 fracture. Manual inline stabilization with
intubation and
intubation.
number is slightly wrong. I think it's C6, C7 because there's 2, 3,
C6,
4,
sorry.
5,
Six.
6,
Six,
7, right?
six.
So this is again no mucking around question, right? It is a fracture. That's it. There's nothing else there. All right.
Okay.
So unstable C-spine with anterior dislocation of C6 vertebral body and posterior dislocation of C7. Agree? This is coming that way. That is coming that way. It's an unstable spine. How will you intubate? So C-spine precaution with cervical collar in place or inline stabilization, preferably fiber optic intubation to avoid manipulation of the neck. So 2 or 3 lines around the intubation. Okay. Complications. So immediate short term and long term what can be. So immediate short term is airway, loss of airway, hypoxia, aspiration, circulation, neurogenic shock, GI, decreased gastric transit, acute gastric dilatation, paralytic ileus. So acute or short term complication. Long term, autonomic dysreflexia, body cast syndrome, GI ulceration, metabolic abnormalities, and all those things. So you need to know basically what are the complications of high C cervical, cervical spine injury or cervical spine transection of the cord. What are the complications and how do you talk about them? How do you classify them? So immediate or short term and long term. Sometimes they are more interested in long term complication. If you have a tracheostomy patient with paraparesis or paraplegia, they will ask about what are the long term complications of C-spine injury, right? So that's the main reason why I have put in the question. So it's not just acute thing. They can ask you about chronic things also. I think that was my last slide. We had 14-15 questions discussion. So the main thing I have put in the CBS because this will be the usual discussion pattern in the course also. We don't talk about a specific question. We talk about the peripheral questions that can be asked in that subject because it's very unlikely that you will get a C-spine, this X-ray in the exam. But what are the questions that can be asked around it is important. You need to look around that, read around it a little bit and have a comprehensive knowledge about it. All right. Thank you for your patience for hearing me. And I think Tapas has answered most of the queries.
Yeah, Dr. Sanan, thank you for this.
Thank you so much.
Thank you.
Yeah, one thing I want to share with you that there is no more MRI, which is right now coming in your CBS. So this is really assuring to most of the candidates because MRI we are not so much of well versed and we regularly don't see and review the MRI. So they have not right now putting the MRI in the CBS, but yes, in the CCS you may get like the MRI findings in one of the clinical case vignettes. So this is one input, and as Dr. Sananda has extensively told, we have almost 250 to 300 CBS questions that would cover the 10 domains in the 3 months. And again, in the last 3 mock test, it would be again 50 to 60 questions. So a lot of practice materials would be there. And every week you would be like focusing on that domain. So definitely you would also make your own question box bank, something like that. And we also advise our candidates, and last time you won't believe, out of the 51 candidates who have joined and almost I think 44 candidates have cleared, it's a huge 85% success rate, and they have prepared their question bank related to each domain. So whether you are joining in our course or not, that's not important, but we always strongly advise that as you go from the very beginning, from the very first week, you should prepare your like question bank related to cardiology, cardiac surgery, neurology, neurosurgery, trauma, so that when you are preparing or revising the thing in the last month, then you don't need to again go back and read from the page number 1 of your book or your materials. So it would be all in detail in your question bank. So you have to just see and get it cleared. So that would save a lot of time, and it's in the last 5-7 days. It's how you manage your time to revise the things. It may be like you have extensively read, but if you are not revising in the last 10 days or 5 days, then when you go to the the real examination, then definitely the questions would be something or entering into some other difficult domain, and you will be having hiccups. So this is the practical experience from the examination what we have got, and that's why I'm sharing with you. So yes, a lot of things are there. So if you want any further information, we are happy to answer those queries. in our WhatsApp group and also in our email. Our email is there in the flyers.